Hi, and welcome to this video brought to you by the Society of Mechanical Ventilation. Obstructive airway disease, asthma and COPD exacerbation.
Hello, today we'll talk about obstructive lung disease and ventilator management during obstructive lung disease. Of course, obstructive lung disease could be COPD exacerbation, asthma, those are the most common, but also occurs in other medical problems like interstitial lung disease. We'll touch base about a quick case. We'll talk quickly about how pathology and diagnosis of COPD and asthma, and mechanical ventilation management. Especially, we'll concentrate on Auto-PEEP, dead space, and Dysynchronies and how to fix them. Quickly about the pathology of asthma and COPD. We all know it, we're not going to spend too much time on it. We all know this tricircle here that could be confusing. People with chronic bronchitis versus emphysema and asthma, and they share this area here. We all know that usually the pathology is bronchospasm, muscle tightening, increase mucus and inflammatory cells. So both of those lead to increased resistance, and the air trapping would cause high compliance. X-rays and CT scans in some cases. Sometimes it's easy to say, oh, this is pure COPD or emphysema. Sometimes it's hard, like we talked about the other one. You can look at the X-ray here again, marked hyperinfiltration, pronounced pulmonary artery, flattened diaphragm, and you can see in this case also like thickened septa, some parts here emphysematous, more pronounced in this one, and of course more pronounced is this one. And of course there's many types of emphysema, but you can see those are the normal lung and those are the emphysematous lungs. We'll talk quickly about the case. You probably, all of you, seen it so many times. 75-year-old male, history of smoking, 45 pack per year, quit 2 years ago. He has history of coronary artery disease, MI, dilated cardiomyopathy, low EF, 35%. He came with shortness of breath for 2-3 days with some dry cough, but really no phlegm, no wheezes, no hemoptysis, no fevers. His home medications: diuretics, beta blockers, ACE inhibitors, aspirin, and long-acting beta agonist and LABA and LAMA. His blood gas on presentation: pH acidotic 726, PaCO2 70, bicarb of 32, PaO2 55, and saturating 85%. Was tried on non-invasive, didn't work, and was intubated. That's his X-ray and is interpreted by a radiologist as congestive heart failure, some encephalization, question of heart failure. On examination, there was maybe question of rales, but no wheezes. There was plus lower, 2 lower limb edema. His respiratory rate was 25. His heart rate was 120. Initially, his BNP was 800. Lactic acid 2.8. His ventilator settings was volume control with low tidal volume 6 ml per kg, I to E ratio 1.2, set at respiratory rate of 20 to get rid of the high CO2, and PEEP of 8. So because of the question of heart failure, he was not given any fluids, but given actually diuretics, and because of hypotension, norepinephrine drip. After an hour, repeat blood gas Now worsening acidosis, acidemia. PaCO2 a little bit higher than initially. Bicarb now dropped from 32 to 24. PaO2 a little bit better, and the lactic acid now is 7.5. So why are we talking about this? It's sometimes very hard to distinguish between obstructive lung disease, for example, COPD, and heart failure. And we know that the chest X-rays we get usually in the ER or in the ICU are the anteroposterior, so not posterior-anterior. So a lot of time it's not even good inspiratory effort. So everything looks crowded and everything looks like heart failure. But in this case, probably people miss that there's a little bit inflation here and flattening of the diaphragms. You can see the right is almost like the left. Usually the right is a little bit bigger. In this case, maybe the heart looks okay, but people usually, if they have pulmonary hypertension, dilated cardiomyopathy, you might see a little bit bigger heart, maybe more pronounced pulmonary arteries. But here, the point I want to make is he was immediately diagnosed as congestive heart failure. And when set on the ventilator settings here, really nobody took a minute or two to see can we distinguish between heart failure and obstructive airway disease based on the ventilator. Then also because of the high CO2, people assume they try to increase the heart rate and assume it's all acute. So they increase the respiratory rate, try to get that pH 7 around normal, 735, 7.4. What they didn't recognize is somebody with, if he lives at a normal PaCO2 of 40, if you go up to PaCO2 of 70, your pH should be much less than that. So for each 10 acute level increase in PaCO2, your pH will drop by 0.08. So if this is all acute, the patient should be pH should be 7.16, but this patient is 7.26. So there's an element of chronic retention with probably PaCO2 of around 50-55. Same here, if you look at the bicarb, there is alkalosis because the bicarb is 32. So usually bicarb we look at from the chemistry 7, not from the ABG, because it's a calculated number. But assume that the PaCO2, the bicarb is 32. So he has alkalosis, whether this could be chronic compensation by the kidney for the increased PaCO2, usually about 5 milliequivalent for each 10 PaCO2, or the patient could be in because of the diuretics. So there's a lot of unknowns here. The other trick was the patient has lower limb edema, and our physical examination is really not adequate, because once we see somebody with lower limb edema, we assume volume overload and congestive heart failure. But also this patient was probably chronic retention of PaCO2 and long time COPD, probably would have pulmonary hypertension and would have like some lower limb edema. Another thing which threw everybody off, that his BNP is elevated. So again, BNP is not made to diagnose heart failure, it's just to rule out heart failure. Patients again with chronic pulmonary hypertension or dilated cardiomyopathy might be living at elevated BNP. It does not by itself say volume overload. So the patient was breathing above the ventilator 25, and if you can see here, he has a lot of work, lot of effort here. You can see that he probably has Autopeep, and we'll talk about those later. He was not given fluids, and again given diuretics and IV pressors. And probably his hemodynamics got worse, to the point as his lactic acid got worse, and that's why now his acidemia got worse as a combination of metabolic and respiratory. Even the PaCO2 went up, probably because of the Autopeep. His bicarb dropped because of the lactic acidosis. So a lot of things to to make decisions when you're examining patients that you're not sure of. But a lot of things to take care of. And please look at the ventilator and use the ventilator as a diagnostic tool, not only as to ventilate the patients. So how are we gonna distinguish between obstructive and restrictive lung disease from the ventilator? This is a patient on pressure control ventilation. He's passive. In this case, I want you to look at something called the time constant. Time constant is basically a product of compliance and resistance, and what it is the time that takes the flow to decay down to 37% from 100%. That's each one is one time constant. So if a normal compliance is, for example, 80 and resistance is 10, the time constant will be 0.8, which is acceptable, somewhere between 0.8 to 1. So in figure A here, again, this is airway pressure in yellow, flow in pink. If you can look here, this is almost a normal respiratory compliance and resistance. Here, the blue arrows are the inspiratory time constant, and the expiratory time constant are in green. We usually try to look more at the expiratory time constant because most of the time expiratory time constant expiration is passive versus inspiration might be active, and it might cloud the picture. But those cases patients are all passive. So you can see here in expiration, the green arrows, patient has 4 time constant, and when about 4 time constants are enough to let the flow go back to almost 0. If you look at this second case here, there is very high inspiratory flow, and the flow goes down very quickly to baseline, same with exhalation. So it means that the time constant here is very short. So this is usually restrictive lung disease, whether that causes ARDS, CHF, pneumonia, whatever you have. If you look at C here, you can tell just by looking that this is an obstructive airway disease. Why? Because it takes the inspiratory flow and the expiratory flow are very low. It takes very long time for that decay, the time constant, to happen, as you can see here. So usually time constant is like 1.5, 2, sometimes it depends on how bad the resistance is. A lot of time it could be confusing, and I had to draw this, I'm sorry. And it could be confusing because the patient who have COPD can have pneumonia or can have ARDS, same with the asthma. So it could be combined restrictive and obstructive lung disease. Also happens a lot in interstitial lung disease. So you can see the first part here is a little bit normal or like restrictive. So you can see it here more in the expiratory flow. You can see expiratory flow low and then decays very quickly. That's the first phase. So those are basically the part with the low compliance. And then after that, the areas of high time constant takes its sweet time to go back, to try to go back before the next breath. And you can see the lung doesn't empty here, so there is some Autopeep, which we will talk about it. So that's one way quickly of looking at and determining to see if that patient has a restrictive lung problem or obstructive lung problem. The other one is the flow volume curve, very similar to here, inspiration and exhalation, and you can see that this is a normal respiratory system or lung, goes back to 0. Here you can see the expiratory flow is very low, more negative, and it goes quickly during exhalation. And here the inspiratory and the expiratory flow are low, and again the time constant is very, very slow, so the lung is emptying very slowly and does not reach the baseline here of 0 at the FRC, so the patient has Auto-PEEP or hyperinflation. A third way of differentiating, of course, we know about the inspiratory and expiratory pause to measure the resistance and the compliance. The patient has to be on the volume controlled squared wave form here, and usually has to be passive, like making no effort. And you will find a high peak inspiratory flow, high peak inspiratory pressure, low plateau pressure, and the difference will be resistance. And of course, if you calculate the compliance, it might be usually high if it's asthma or COPD. So let's look at a patient here with a pure COPD, and I made this patient as very high compliance, almost 80 or 100, and very high resistance also, about more than 30. So just a quick diagnosis. How do we know that this patient is COPD without even measuring anything? So of course, you would look at the peak airway pressure would be high. This patient is in volume controlled mode. Um, with constant flow, square waveform, inspiratory time of 1 second. I put a pause a little bit so we can measure the peak and the plateau pressure because the simulator does not allow inspiratory pause. His rate is 24, tidal volume 400, speed of 5, and FIA to 21%. So the first thing that makes you suspicious of obstructive disease, whether it's asthma or COPD, you have very high peak inspiratory pressure. If we put a pause here to see what's the plateau, you have a plateau of 14 and a peak inspiratory pressure of about 30. So the difference is almost 15 with a flow of almost 30. So the resistance will be peak 30 minus plateau 15. That's 15 over 30 liters per minute, which is 0.5 liter per second. So resistance becomes 30. So that's quickly. How about the flow? If you look at mostly the expiratory flow, because the inspiratory flow will be influenced by many things, of course, the respiratory mechanics, the work of the patient, um, the here by the inspiratory time. Or if in other ventilators you set the inspiratory flow, so it doesn't give you much information. What gives you much information is the expiratory flow, because most of the time expiration or exhalation is a passive condition. Although, of course, in a lot of time the patient can be working hard and it can be active. But if you look here, the flow is only minus 18, so that's very low flow. The other thing that we can notice is if you look at the something called expiratory time constant, which is we talked about it, the time of decay of the expiratory flow, usually to reach down to 37% of the peak expiratory flow. That's one time constant. So if we're from 18, 37% is usually like about 6. So here the patient does not even reach the 37% because before the next breath starts it's only minus 13. So this is a very long expiratory time constant. And if you look at this ventilator here, the Hamilton, it actually gives you something called RC expiration, which is the expiratory time constant, which is 4.2 seconds, which is very, very high. The normal is usually about zero point 0.8 or zero point 0.8 seconds, 1 second, something like that. So just by looking at this patient, you can tell that he has an obstructive problem. Um, of course, versus ARDS, and we talked about it in other cases, the expiratory flow is very deep, minus, um, very minus, like minus 60 or something like that. And the expiratory time constant is very short, depending, of course, on compliance and resistance. So usually exhalation is very deep and collapses very quickly. Um, the other thing I want to mention is that volumetric capnometry, and it's very important actually in every patient in respiratory failure, especially in COPD patients. So, of course, this graph is a simulated graph, so might not be very, very accurate. But usually in obstructive disease, you have this is phase one, so you have which is the anatomical, usual anatomical dead space. So it's usually very prolonged. This phase two, usually the mixing part, and phase three, which is the alveolar dead space, usually In COPD patients or bad obstruction, you would see like a very high slope going up like this, not a nice square. Um, so it's very important again to look at the CO2 volumetric capnometry, because it measures for you the anatomical dead space, VDAW. It measures the alveolar tidal volume, and of course the end tidal CO2. And if you plot the airway, the anatomical dead space on the total tidal volume, it gives you the percentage of the dead space, which is here 35. 35 is not too bad, but some people with bad obstruction, it could be very 40, 50, 60%. So our management would depend on correcting all of those problems that we see in those patients. Another problem with, of course, any obstructive lung disease, whether COPD or asthma, is Auto-PEEP. And as we talked before, if if the expiratory flow is not reaching the baseline before the next breath, this is Autopeep just by visualization. But we need to correct the Autopeep because of the problem with over distension, asynchronies, increased work of the patient to trigger, and we'll show some asynchronies later. So how are we gonna measure the Autopeep? This patient now is on tidal volume 500, PEEP of 5. Um, the expiratory time constant is 3.15 seconds. So how are we going to measure it? We have to do an expiratory pause or hold maneuver. And here we go. So if you go to here, you find that the total PEEP is about 13.5, although we dialed PEEP of 5. So the auto PEEP is about 8.5. So how are we going to get rid of this auto PEEP? Some people tell you increase the flow or decrease the inspiratory time, but usually it does not have that much of an effect. So we're gonna go down here from 1 second, for example, down to even 0.6 second, and then we'll measure again our auto peep. And of course, you can see here once we decrease the inspiratory time, the pressure would go up. But let's measure again. Okay, our auto peep now dropped down to 10.7, but of course our airway pressure went up. So what's most effective is reducing the respiratory rate, basically the minute ventilation, so the respiratory rate and the tidal volume. So of course it's not sometimes so easy to reduce both because the patient, you need to be heavy sedated or even sometimes paralyzed if they're fighting the ventilator, having a lot of dysynchronies. But to prevent auto-PEEP, you need to reduce the minute ventilation. So we dropped tidal volume to 400, the respiratory rate now is 15. We'll go ahead again and measure again. Okay, and now the total PEEP is 6.9, um, much better than before. And of course, the more you reduce the minute ventilation, uh, the auto PEEP will improve. But of course, you have to make sure um, while you're doing this, your CO2 is rising too high. This is end-tidal CO2 46. The dead space is still 35. And of course, you're doing all these maneuvers while you're trying to treat the case. One of the other things in the literature is to increase the applied PEEP to almost 80% of the auto PEEP. So, and that sometimes reduce the auto PEEP. So if you go, say you have an auto PEEP uh, total PEEP of 10, you can't reduce it by other means. If you increase the applied PEEP to 8, it might actually help reduce the amount of auto PEEP and might decrease the synchrony of the patient, especially the wasted effort. I just want to show this graphs here. This is a patient with COPD with very high resistance, and I just want to concentrate on some of the asynchronous that happen. If you can look here, this is a patient effort that had caused very delayed triggering of the ventilator. The reason for this is auto-PEEP.
if you can see something like this is probably a totally missed effort. The patient tried to breathe like this one. This is a patient effort, but he could not overcome the auto-peep. So that caused, um, the breath to be wasted. Usually, as soon as the patient trigger, you will have breath after it. So you can see it here again. So of course, all those asynchronies, because cause wasted effort, increased work of breathing, uh, im- worsening time on the ventilator. You can see here this one is delayed triggering because it took like almost zero point 0.3 seconds or something to for the breath. So that's why the importance of auto-PEEP not just only on hemodynamics but also on patient effort and work of breathing.